Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Rouleau University Medical Center. I'm Ronak.
And I'm Dan.
And today, Vivek is away, but we're so excited in today's episode to be on our next part of our prostate cancer series. This time we have a fantastic guest with us, Vineetha Thomas, coming to us from the Stevenson Cancer Center at the University of Oklahoma. She's a clinical pharmacist specializing in GU clinical pharmacology, and we're so excited to have her on the show. She's going to add so much insightful information, and we can't wait to share that with you all. So without further ado, let's go ahead and roll that show. All right, guys. So we are so excited today to have one of our guests joining us in our prostate cancer series. This time we have Dr. Vineetha Thomas, who is a GU clinical pharmacist at the Stevenson Cancer Center at the University of Oklahoma. Vineetha, thank you so much for taking the time to join us this evening.
Thank you so much, you guys, for having me.
You know, we're really excited. And as we've said before in a lot of our episodes, where our pharmacists are our guests, you guys are such a big component of our care team, looking after our patients, especially counseling our patients, helping us choose our regimens. And so it is always so insightful for us to be able to kind of pick at your brain and see what the thought process is and see what these conversations are so we can better integrate that into our management strategies as well as our counseling of our patients. So Vineetha, something that we love asking all of our guests when they come on the show is to tell us a little bit about yourself and one fun fact.
So I work in the GU clinic at the Stevenson Cancer Center. It's my full-time job. I don't know about the fun part after having two little kids. I don't know if there's anything fun that's left back in me. But one interesting fact is that in the last year, I've started collecting some indoor plants. And for all my life, I have struggled to keep plants alive and they all die on me within a week. But it's been quite impressive the last year. I mean, my house is kind of filled with plants now, and we have a outdoor patio now that we've covered and just dedicated to our indoor plants. And I love my cacti and succulents. So that's been my latest passion. They really have a calming effect after a hard day at work.
I love that. Yeah, coming home, just having this nice little indoor garden to take care of, look after. That's great.
Yeah.
Yeah, that's really, really great. My dad and mom were actually visiting me not too long ago, and we repotted a lot of the plants that I have. Granted, they were in pots that were way too small for the size of the plant. And in the last couple of weeks, these things have shot up at least 2.5 feet, at least the one plant has. So I am slowly becoming a plant dad as well. So I completely agree with you when it comes to that calming effect. I really just I love looking in the corner and seeing my babies growing before my eyes. It's pretty fantastic. But let's switch gears a little bit to talk about why we're here tonight. Thanks again for joining us. And I think I'll just kick it right off and we'll get the ball rolling. So Vineetha, an important backbone of therapy that we use in prostate cancer treatment is the class of drugs that act as androgen deprivation therapy. And, there's really quite a few options to pick from, including GnRH agonists and antagonists. Can you briefly describe what the difference is in terms of the mechanism between these classes? And what guidance do you have to help us select one over the other?
Yeah, that's a great question. So androgen deprivation therapy is the backbone for prostate cancer treatment. And we have all these different GnRH agonists that are approved. We have leuprolide, goserelin, triptorelin, and in the GnRH antagonist class, we have relugolix, brand name Orgovyx, and we have Pharmagon or Tigarelix. So when it comes to mechanism of action, the GnRH agonists, just like the name suggests, they act on the GnRH receptors. They go and bind to the GnRH receptors on the pituitary gland, and then initially they cause an increase in FSH and LH, so which in turn leads to an increase in production of testosterone from the testes. Now, with this initial GnRH agonist action takes place, there is initially a surge in testosterone. And after some time, there is kind of a downregulation of these GnRH receptors, and which leads to like a negative feedback mechanism with the hypothalamus, and that eventually leads to lowering of serum testosterone levels. Whereas with the antagonists, they straight up just go and block those GnRH receptors. So there's an immediate reduction in FSH, LH, and testosterone levels.
It makes a lot of sense. It's sort of analogous to how, starting warfarin, it increases your risk of coagulation at first before it sort of tapers off and gets its therapeutic effect. But yeah, could you go into a little bit of how you choose between those options?
Right. So as far as choosing, it really depends on, unfortunately, what insurances will allow most of the time. So between the three approved GnRH agonists, there have been no comparative head-to-head trials, but all of them act equally fine. So whatever your institution has on formulary and whatever the insurance will approve for a patient. So most of the time at our institution, we just pick leuprolide and we stick with it. Now, as far as going between the agonist and the antagonist, again, insurance approval, unfortunately, because we do not use degarelix, the injectable form of the antagonist at our institution. And I'm thinking that's primarily because of the cost. Cost is one of the main reasons, because leuprolide is now available in generic form, whereas Formagon or degarelix is not. And another reason I am thinking is because degarelix, the injectable form, has to be given once a month. So it's more inconvenient for patients to just come in every month. And also, degarelix has a pretty high rate of injection site reactions. So it can be an uncomfortable injection for patients. So that's probably another reason why our institution has always chosen leuprolide. And that is our typical go-to. And as far as like between the antagonists, if we have to go with the oral option, again, it's insurance approval. Sometimes that can be a very high, expensive copay. There are, assistance options available for patients, but for patients that do not have the copay card, like options, if they have commercial insurance, they do have the copay card option. But if they do not, then, we just really have to evaluate, because insurances will ask for a pretty convincing reason why you cannot use the leuprolide or one of the other options before they will even approve it, and also for the sake of high copay. Another reason that I would think about is in the phase 3 HERO trial that got the antagonist relugolix approved, they found that the rates of major adverse cardiovascular events were lower with relugolix when compared to leuprolide. So for somebody who has a pre-existing, cardiovascular comorbidity, I might recommend relugolix, and I have seen physicians choose that over, the agonist. So those are some of the reasons we choose one over the other.
And you'd mentioned the dosing frequency for degarelix once a month, and leuprolide is the one I'm most familiar with of all of these axis of meds. But I recall from my brief stint as a medical oncologist in fellowship that the frequency of dosing was different. I think there were like multiple options. What is the frequency for leuprolide?
For leuprolide, so it comes in several different options. So there is a 7.5 milligram intramuscular injection that's given once a month. There is a 22.5 that's given once every 3 months. They have a 30 milligram that is given once every 4 months, and a 45 milligram dose that can be given once every 6 months. So really what the physicians and patients prefer to use more often. To be honest, at our institution, we use the 3-month more often than the others. There are some patients that we use the 6-month as well. But yeah, there are quite a few options for leuprolide.
And, to follow up on that, I'm also quite familiar with using leuprolide in our clinic patients. And every now and then we have patients that are coming in with side effects. And I'm curious, what are the major side effects that you counsel your patients about when they're about to start androgen deprivation therapy?
Yeah, so when I counsel them, I give them fair warning about the hot flashes that's coming. So that's one of the big ones that we see all the time. So I tend to counsel them with like all non-pharmacological management first before we try to put them on something for the hot flashes. So I try to counsel them to try keeping the room cooler, try dressing in layers, so you can just remove the outer layer if you feel like a hot flash is coming. Avoiding things like spicy food, alcohol, and things like that, just non-pharmacological management. Other points that I counsel them on are LHRH agonists can cause bone loss over time. So I counsel on the importance of calcium and vitamin D supplementation. I make them go ahead and get started on over-the-counter calcium vitamin D supplement. We also talk about long-term cardiovascular health and optimizing things like blood pressure, dyslipidemia management, if they have to get a referral placed to a cardiologist. I talk about the importance of diet and exercise, healthy diet, especially because androgen deprivation therapy can cause loss of muscle mass with time. So the importance of exercising as tolerated, light to moderate weight-bearing exercises if possible. And just for the fatigue, the importance of staying active to beat that fatigue. Yeah, those are some of the high points that I counsel them on. And specifically for the relugolix, the oral GnRH antagonist, I always talk to them about if they miss their medication for more than 7 days, which is a possibility because many of these patients have, older gentlemen, they're on a lot of other medications as well. So I have had scenarios where people go on vacation for, a couple of weeks and they forget to take their medication with them. But if they forget to take their medication, the relugolix, for more than 7 days, then they need to go back on the loading dose. So the dose for day 1 is 360 milligrams. So it's 3 tablets on day 1, followed by 1 tablet every day thereafter. So I just counsel them on trying not to forget their medication and the importance of reloading if they have forgotten to take their medication for a week or more.
That's so helpful. I thankfully have not had anybody have that issue yet, but now I feel like it might just come knocking on my door and I'll know what to do. So that is great insight. So Vineetha, as a follow-up to that, one of the biggest complaints that, as you alluded to, that my patients complain about sometimes are the hot flashes. And I also notice, though, not everybody gets them. And I'm just curious, are there things or strategies that patients can do sort of preemptively to try to prevent them from happening in the first place?
Unfortunately, nothing other than, little things like I said, keeping the room cooler and lighter dressing. Nothing that we can do preemptively. However, if it turns out to be like a major problem for the patient to where they feel like, they don't want to be on androgen deprivation therapy, or they start expressing a lot of concern, at that point, we might start considering like pharmacological options. And our go-to option is venlafaxine. So it has proven to be useful in our patient population. There are a lot of patients that we put on venlafaxine, and we start off at that lower dose of 37.5 milligrams, I believe, for the first week. And if they're able to tolerate it well, then I bump it up to 75 milligrams. And most of them have not had complaints after the venlafaxine. So that is our go-to.
That's pretty cool. That's pretty analogous to what we see in breast cancer pharmacology too. I remember that from one of our breast cancer episodes, talking about side effects of hormone therapy there. If a patient is really intolerant or maybe they're not interested in venlafaxine, do you ever get any benefit from switching from a GnRH agonist to an antagonist? And if so, do you need to let the first one wash out a little bit before starting the antagonist?
So anecdotally, I've had a handful of patients that, just refuse to be on the leuprolide injections. And we switch them over to the antagonist relugolix, and anecdotally, they report that, they'd rather be on the antagonist, the relugolix. So yes, so like you said, we give them a 3-month shot, then I kind of wait for that 3 months until, the time for the next shot before we put them on the antagonist. But yes, there have been patients who have found the side effects to be much more better tolerated. Even the fatigue too, that patients have told me that, especially some people, when they get that first injection, the first couple of weeks after they get that injection, they might experience a lot of fatigue and, just depression and, effects on the mood. But on the antagonist, they're able to tolerate that better. So that is a reasonable option.
That's great. And I want to switch gears a little bit to another really important class of drugs that we use in the management of our prostate cancer patients. And that is the non-steroidal anti-androgen options, such as darolutamide and apalutamide. How are these different than the agonists and antagonists that we just discussed?
Yeah, so these novel hormonal agents, there are three medications, enzalutamide, apalutamide, and darolutamide. Unlike the GnRH agonists and antagonists, they are pure androgen receptor signaling inhibitors. So they basically competitively inhibit, the binding of androgen receptor to testosterone, and they prevent the translocation of the complex, the androgen receptor testosterone complex into the nucleus and further DNA transcription. So these agents, just act very differently from the agonists and antagonists. And the side effects of these three, there are some nuances between, the three of them. But basically, enzalutamide can sometimes cross the blood-brain barrier and cause some side effects like dizziness, and so can apalutamide. Whereas darolutamide does not cross the blood-brain barrier. So we don't see those rare side effects like dizziness and even possible seizures with the other two agents.
I feel like that was something that I saw as I was studying for boards. Like there would be these practice board questions that would be like, oh, this patient has a history of seizures. What drug do you want them on? So I kind of get where that's coming from.
Yeah, I go over and look at my patient, like every new start of enzalutamide and apalutamide. I go through the med list to see if they have any history of, any anti-epileptics in there. And I also ask them if they have a seizure history. And even if they don't, we have had about 1 to 2 patients that develop seizures after putting them on enzalutamide, and we had to permanently discontinue them.
Oh, wow.
So that's a possibility with these agents.
As far as sort of steroidal anti-androgens, I feel like one of the ones that the most common drugs I see used here at Rouleau is abiraterone. Are there some sort of like important things to keep in mind there in terms of starting a patient on that and sort of toxicities that you expect with these agents in particular?
Yes. So with abiraterone, we closely monitor the labs with this medication. It is a competitive inhibitor. It competitively and irreversibly inhibits CYP17, an enzyme that is required in the biosynthesis of androgens. So we do a baseline CBC and a chemistry before we start them, because these agents can sometimes cause things like hypokalemia and elevation in LFTs. So, and also hypertension, significant hypertension. So just looking at those LFTs. In fact, the package insert recommends that when you first start them, you need a baseline CMP, and then every 2 weeks for the first 3 months. And from then on, if everything is normal, you can go to monthly monitoring.
And then I've had patients ask me about the steroid that we give with it, the sort of the glucocorticoid, I should say. And they've told me like, oh, he can't take a steroid. His blood sugars will go crazy. And I always try and explain it's to replace something that we're taking away, right?
Right. Yeah. So when we block that CYP17 enzyme, that leads to a reduction in serum cortisol and a compensatory increase in the adrenocorticotropic hormone, ACTH. So, and that can lead to some mineralocorticoid side effects like hypertension, edema, hypokalemia. So it's just to mitigate those side effects that we are supplementing with the glucocorticoid. So I try explaining to them. I've had the exact same scenarios where sometimes patients get a little too worried about, their blood sugars going crazy. So I tell them it is a small dose and it's just to compensate for that reduction in serum cortisol. But yes, so in the castrate-sensitive setting, when they studied abiraterone, the FDA has approved this medication to be given with prednisone 5 milligrams once a day, whereas in the castrate-resistant setting, the dosing for prednisone is 5 mg BID. That being said, sometimes in the castrate-sensitive setting, or even if a patient takes a 5 milligram once a day dose, and if they tend to develop some of these mineralocorticoid side effects, I have seen providers just bumping up that prednisone to 5 mg BID before they go for a actual dose reduction to kind of see if that helps. And sometimes it does.
To that point, is there ever really a role for a dose reduction? And can patients still get benefit from a reduced dose of the abiraterone, or is it just better to switch them to something else?
No, I think there is definitely a role for dose reduction. We've had patients with LFT elevations, like significant LFT elevations, when they're on the full dose. So typically when I see those LFTs go up to like borderline grade 2 or even, high grade 1, we put the medication on hold. And then after the LFTs have resumed and come back to normal, then we go to like 750 milligrams of abiraterone once a day. and they still continue to get benefit out of it. So the package insert says you can go up to 500 milligrams dose reduction, but after that, I would just discontinue it. But a lot of our patients are able to overcome the LFT elevation at a lower dose and stay on it.
And Vineetha, while we're on the topic of this class of agents, one of these, and speaking of studying for boards, this question does come up every now and then. They ask about bicalutamide, and quite frankly, I haven't really seen this as the primary treatment modality for a lot of patients. Mainly when I've seen this, it's for patients that have really significant burden of disease, like in a new diagnosis while they're in the hospital, especially in patients that have new metastatic disease to like the spine, for instance. So if we are using bicalutamide for this purpose, for the purpose of, blocking and preventing and this surge of testosterone that's going to happen from our agonist medications, how long should we be putting patients on this drug while it's overlapping with another agent?
So typically, all you need to do is overlap it for 7 days or more. Typically, what we do is we start them, like you said, if they have mets to weight bearing bones or, huge disease burden. What we do is we send in a 30-day supply of bicalutamide, get them started on it in about, 7 to 10 days, get them scheduled for their leuprolide, have them come in, and then just have them finish off that, like 2 weeks after their Lupron dose. So that way, all those receptors are still blocked while that testosterone surge happens. And
out of curiosity, at your center, do you all ever use bicalutamide outside of this very specific setting?
No, we don't ever. I don't ever see it used. With the advent of all these, novel hormonal agents, we don't use it as the primary form of androgen deprivation therapy anymore. I know back in the day, before the advent of all the novel hormonal agents, they used to do that. Bicalutamide at a slightly higher dose, 150 milligram dose, I believe, just by itself. But I don't see that done anymore.
And we talked about enzalutamide a little bit earlier, just as one of the other drugs, specifically in its potential for causing seizures. But I've also heard about having a role when there's biochemical recurrence. What's the story with that?
There was this EMBARK trial that was recently published in the New England Journal of Medicine, and our providers have started using enzalutamide along with androgen deprivation therapy for high-risk prostate cancer with biochemical recurrence. When that PSA starts rising, we've started putting patients on ADT and enzalutamide. Typically, I believe it's done for 9 months, will be the duration of treatment from what they saw in the trial.
I think it's so exciting that we are literally recording this series in real time as prostate cancer therapy is changing. And so we will certainly, listeners, go into a little bit more about the EMBARK trial when we get to that section of our series. But, it's great to hear that we're already utilizing this in the clinic, and it's been approved for only a few weeks now, which is great to see. Vineetha, with the advent of so many hormonal therapies, as we've been talking about, it seems that we're going less and less, or rather we're using chemotherapy less and less these days for the treatment of prostate cancer. That being said, though, when do you see and what situations do you see cytotoxic chemotherapy still being utilized for our patients?
So when these patients have progressed on multiple, novel hormonal agents, and they get to that metastatic castration-resistant setting, then I think there is a role of cytotoxic chemotherapy at that time. Also, we use it for de novo metastatic, hormone-sensitive metastatic disease as well. So when somebody comes in with, huge disease burden, high volume disease, metastatic, then we tend to go with cytotoxic chemotherapy. If they're able to tolerate chemo, then we'd like to go ahead and start chemotherapy for high volume disease.
And is there a preferred agent that you guys are reaching for in these situations?
Yes, docetaxel is the first line of chemotherapy that we use in prostate cancer. So in the metastatic hormone-sensitive setting, we use docetaxel. Now with the approval of the triplet regimens, with the publication of the PEACE trial results and the ARISENS trial results, we are using considerable amount of triplet regimen in patients who have high volume metastatic hormone-sensitive disease.
Could you remind us what triplet therapy is once again?
Yes, so triplet is ADT plus docetaxel plus either abiraterone based on the results of the PEACE trial, or you can do ADT plus docetaxel plus darolutamide based on the results of the ARASENS trial. At our institution, we like to go with docetaxel plus darolutamide because honestly, darolutamide is tolerated much better than docetaxel plus abiraterone. There are a lot of overlapping toxicities that we see with both docetaxel and abiraterone because both these agents can cause the LFTs to go up high. And to be honest, darolutamide is I haven't ever had anybody complain with darolutamide. It's very rare. There have been some occasions of diarrhea and things like that, but for the most part, people tolerate darolutamide much better.
Just to change gears a little bit here and move away from, I guess, not really pharmacology, chemical treatments. One thing I remember feeling really excited about when I was in fellowship learning about prostate cancer therapy was this sort of concoction, sipuleucel-T, which I think was at least the first cell therapy in a solid tumor that I can remember hearing about. But I remember not seeing it used that much, at least not in my clinic. Can you talk a little bit about this? Like, what exactly is it and when do we use it?
So sipuleucel, brand name Provenge, it is what we call a autologous cancer vaccine. So we use it in the metastatic castrate resistant setting. When we see that PSA just going up high and they are asymptomatic, patients have to be asymptomatic if they have to get on this therapy. Asymptomatic or minimally symptomatic, to the point where insurances will ask you this in the prior authorization that if they are on a long-term or a long-acting opioid, if you have to get this treatment approved.
Oh, wow.
What we basically do with sipuleucel is about 3 days before the patient is set to start their treatment, we coordinators send them to a blood institute for leukapheresis, where their white blood cells are collected and the antigen presenting cells are isolated. They're they're shipped off to the Dendreon, the manufacturing facility. And there, these cells are kind of manipulated to attach these components, which is the prostatic acid phosphatase, PAP, and another component, which is immune cell activator, which is GM-CSF, this granulocyte macrophage colony stimulating factor. And then they're cultured with the patient's antigen-presenting cells for, I believe, about 40 hours. And then these cells are then infused back. They're shipped all the way back to our facility when a patient comes in for the treatment. And it is kind of tricky to get all of this organized and, coordinated. And there's a lot of logistical steps that's involved in this process. So basically, when the package arrives or shipped back from Dendreon, you have to coordinate the patient's infusion appointment same day. In fact, within a couple of hours, because once you open that box with the cells, with the bag of sipuleucel, it will expire 3 hours after you open the package when it's at room temperature. So it can be challenging sometimes. And then, so these cells are then infused back into the patient. And then this should induce an immune response from the T cells. And the T cells are supposed to go and attack these manipulated antigen presenting cells.
Yeah, I'm starting to see why maybe we don't see it used all that often. Between a very narrow indication for use and a lot of practical barriers to logistical barriers to making it happen, that sounds like a real challenge. But basically sensitizing antigen presenting cells to a specific antigen, letting the T cells do their thing. What kind of side effects do you look out for when somebody's on that, if you're able to actually achieve a successful infusion?
Yeah, we do use it quite a bit in spite of all of this. Some providers like it more than the others. So we do see it these days. It is very well tolerated. So there's not many side effects that you see. Haven't had anybody complain of any side effects except for the hypersensitivity reactions that can occur during infusion.
Got it.
So there is some pyrexia, some flu-like symptoms, headaches that can happen when they get the infusions. Again, another big problem that we run into is when they have these fusion reactions, you have to interrupt the reaction, interrupt the infusion and then take care of the reaction. So then that bag of sipuleucel is just sitting out there at room temperature while the infusion reaction is being managed. And then at 3 hours, you just have to discard the bag. So that's something to think about, when initiating these patients on sipuleucel.
It's good to know that the drug doesn't have that many side effects, because as we've discussed many times, quality of life is something that is super important in our patients, especially those with metastatic disease. And, if these patients are already asymptomatic and then we're subjecting them to symptoms, are we really doing them a service? And so it's great to hear that that is something that is not necessarily as burdensome for these patients that are on this medication.
Right. And most patients are, happy after they've received their medication, because most of the time with cytotoxic chemotherapy, with all the side effects that can happen, you put them on all these different other drugs to take care of those side effects. Whereas with this, you can manage those reactions at the infusion center right there. We just pre-medicate them with acetaminophen and, diphenhydramine, and possibly just have some PRN meperidine on hand in case of those rigors. But other than that, it's tolerated just fine.
And similar but different to that drug is also radium-223. I've also never seen this used. And so similarly, what are the indications for its use? And, when should we be considering this drug for our patients?
Yeah, so radium-223, brand name Xofigo, it is a radiopharmaceutical agent. So this is a suitable option for a patient who has metastatic castrate-resistant prostate cancer with bone-only mets. No visceral mets, because this radiopharmaceutical agent is a calcium mimetic. It likes to go and specifically bind to those areas where the bone mets are. So these are basically just high energy, short path alpha emitting agent that, just exerts its action on those areas of bone mets. So it's given once every 4 weeks for about 6 doses, I believe. And our radiation oncology department takes care of it. We refer them to radiation oncology. And this is also pretty well tolerated. I do not see a lot of complications with this. Sometimes we do see there can be some mild myelosuppression. The idea is that since these alpha particles are a short path, the idea is that they will not attack the surrounding cells, the cells in the bone marrow. So it does not cause profound myelosuppression as chemotherapy agents would. So however, we do see small degree of myelosuppression. And sometimes a thrombocytopenia can be a reason for dose delay, and some mild nausea, vomiting, and diarrhea, which can be managed with supportive care agents.
Wow. So that's not bound to a targeting agent or anything. It's just the radium, and it kind of goes to bone on its own. That's pretty cool. I've also heard of, using lutetium-177 or lutetium. I only ever read the word. I'm not sure how it's said. 177. And I know that for things like neuroendocrine tumors, that's bundled up in a carrier molecule that targets it to the neuroendocrine cells by the sort of somatostatin receptor. For prostate, when we're using lutetium, is there a targeting molecule attached to that?
Yes, there is. So we typically get a PSMA scan for these patients. We order a PSMA scan, and it's only for patients that have metastatic lesions that are PSMA positive, so prostate-specific membrane antigen positive lesions. So only for those patients, this medication is indicated. So it can be used in a metastatic castrate-resistant setting for patients who have progressed on prior docetaxel and a novel hormonal agent. And if they have positive lesions on a PSMA PET scan, because this lutetium-177 molecule is, bound to this moiety that just goes and it's specifically binds to the PSMA expressing prostate cancer cells.
That makes sense. So it really is quite similar to how we use it in neuroendocrine. It's basically you can pop it in the same thing that you're using for the scan, but it's just instead of being a signaling type of radiation, it's a lethal type of radiation for the cells. Okay, that's very cool.
We sort of touched on this just a few minutes ago when you were talking about some of the pharmacological therapies that you prescribe to your patients, including calcium and vitamin D and things like that. And you also discussed quite eloquently about the importance of bone health for our patients. So is there a role for patients to get DEXA scans? And, when should we be also then reaching for things like bisphosphonates if we know that bone density problems can arise in patients on therapy?
Yes, because androgen deprivation therapy can cause an increase in, bone turnover and loss of bone mineral density. it is recommended that we do a baseline DEXA scan for all patients that start on androgen deprivation therapy. And now, if the DEXA scan comes back and shows that the patient has osteoporosis, then we should definitely start them on a bisphosphonate or denosumab. Now, the indication or the dose for osteoporosis is different from, when we use bisphosphonates or denosumab for like skeletal mets. So the dosing is different. So if the DEXA scan shows the patient has osteoporosis, then we can give them zoledronic acid, Zometa, 5 mg annually, once a year is all they need. Or if the DEXA scan shows that patient has osteopenia, bone loss, and they are on ADT, then denosumab is also approved in that setting. So you can use the 60 milligram dose once every 6 months to make sure that it doesn't get any worse while they're on androgen deprivation therapy. And it is recommended that we do that baseline DEXA and then repeat it a year after just to see that we're getting a response with these agents.
That's great. It's good to know. It's something I definitely have worried about, and with any kind of hormone therapy for this or other cancers that respond to it. I think that was a really great discussion overall. We took us all the way from manipulating the GnRH axis with agonists and antagonists to steroidal and non-steroidal antiandrogens and how to sort of mitigate the side effects of manipulating testosterone. And through some new data related to enzalutamide, again, we're going to get into in more detail in a later episode. And then some of these other non-chemical therapies or radiopharmaceuticals, which I guess are sort of chemical therapies, and a cellular therapy for a solid tumor. So a lot of really cool stuff in prostate cancer, seems like.
Yes. It was really exciting to be part of this conversation. And I just love talking about prostate cancer drugs all day long because that's what I do at work.
And I want to say how insightful this conversation was, just because these are conversations that we need to be better about having with our patients when we're starting them on these therapies. We are fortunate that we also work at a place that have fantastic clinical pharmacists like yourself. But, I can imagine that this is not the case everywhere. And so a lot of that onus does happen to fall on the clinician. And we are often not given that sort of guidance or experience providing this counseling. So this is so helpful. And I want to thank you for, taking the time to be here today. Just any final thoughts or remarks or concluding comments that you want to make before we wrap up for today?
Yeah, I think it's really exciting to see all these, new approvals in prostate cancer and all these oral agents that we use. And there is a tremendous role, like you said, for pharmacists. And it is really exciting. And one of the things that I forgot to mention earlier was with all the novel hormonal agents, there are a lot of drug interactions. I totally forgot to mention about that earlier. But with drugs like enzalutamide and apalutamide, they are notorious for having a lot of drug interactions, especially with anticoagulants. So that's something that I do every day on a day-to-day basis, just looking at patients' med lists to make sure that there are no drug interactions either. So while it is exciting to have all these new treatments available, it also poses some challenges to, just for us to be proactive and take some steps to make sure we give our patients the best possible care.
And that's why we appreciate you guys so much for all you do to help us and for our patients as well. I do also briefly, before we wrap up, also want to thank our friends at the Pharmacy Podcast Network for putting us in touch with you. And so we're really excited to be partnering with them, especially for these episodes where we highlight our clinical pharmacists. So thanks to Todd and his team over there for creating this connection. All right. Well, I think that wraps up another fantastic episode of the Fellow on Call. Thank you again so much, Vineetha, for joining us. And until next time, listeners, we'll see you all later.
Thank you.
See you later.
Bye.